get going. Yeah, hello everybody, happy Friday, and welcome to our long-term care learning series. For those of you who don't know me, I'm Sarah Metcalf. I'm one of the program managers in long-term care, and I'll be moderating our session today. Just a reminder that this session is being recorded and will be posted on our YouTube channel and on the intranet for anybody to access later on. This is also where you can find our previous recordings if you've missed any of our last few sessions. First of all, I'd like to acknowledge today that I'm a visitor working on the traditional unceded territory of the Lekwungen speaking people, known as the Saanich, Songhees, and Esquimalt peoples. Please take a moment to reflect on and acknowledge the lands that you're coming to us from today. I'd like to thank you guys for joining our learning series today. Marina and I thought this would be a good opportunity to review our response protocol and any changes and updates that have gone in recently. We're also excited to have Emily Pridham, Marlene Montgomery, and Lisa Young joining us today on our panel. So if you guys have any questions you'd like to ask, please post them into Slido or into the chat box, and we'll review them after a quick presentation by Marina. I'll also post the link to the Slido and a short survey to get your feedback about today's session in the chat box as well. So with that, Marina, I will hand things over to you.
Awesome, thank you, Sarah. Hi, everybody. My name is Marina Lang. I'm the intern clinical nurse specialist for the long-term care program and one of the members of our awesome long-term care COVID response team. So today we're going to be talking about the long-term care response protocol. And there's been a few changes that have happened with it in the last couple months that are worth reviewing and just sort of putting the opportunity out there to ask questions to our response team members and make sure we have a good understanding of where we're at right now with our response protocol. So some of the learning objectives we'll go over today are to discuss the difference between enhanced surveillance versus outbreak. This was a change that occurred a couple months ago based on the ministry's release of outbreak management protocols. And so this is something that's been integrated into our response as well. We'll talk about some considerations for what it looks like when a staff member is positive versus a resident. A lot of the language in the original sort of iterations of the response protocol were focused heavily on residents. And we've learned over the course of our time here and with responses to various outbreaks that the staff member piece is an important bit, and it does sort of, it kind of is its own thing and may have a different approach than what we'd be considering for our residents. We will also talk a little bit about contact tracing and its role in outbreak management, with a lens on how the site might need to support contact tracing should there be an exposure at the site. There has been a recent update to transfer, so we'll discuss that change and how the process looks now. And then we'll dive in a little bit into when an outbreak is declared over and sort of the steps that are taken there and what the sort of takedown and disassembling of an outbreak looks like. And then as always, we'll have time for discussion and questions from you guys who have joined us today. So thank you for your time as well. So with the ministry guidance that was released, I believe it was early February, if I'm not mistaken, there were definitions added for what enhanced surveillance looks like versus when an outbreak needs to be declared. So the original definition of the outbreak, and one that was in use up until about February of 2021, was that an outbreak would be declared in long-term care if a single staff or resident was determined to be positive. Now what we have with enhanced surveillance is that enhanced surveillance is sort of the first declaration, and that means that there has been an initial case identified at the site, and that can be a resident or a staff member. but at this time, there's no evidence of transmission at the site. So an outbreak will be declared, and we have definitely had situations where a site was on enhanced surveillance, and then based on testing and further investigation, it was evident that transmission had occurred at the site, and then they were upgraded to outbreak status. So when a site is under enhanced surveillance, it's the testing strategy is based on the case investigation. And part of that case investigation is understanding the types of exposure, who may have been exposed to the infectious person, how long those exposures looked like, what PPE was being used at the time, and then sort of a risk determination is identified, and people are either sent for testing or advised to self-isolate based on that case investigation. During enhanced surveillance, there's no changes needed to visitors. So social visits may continue, as well as, of course, essential visitors. Depending on the nature of the enhanced surveillance, it may be advised by our medical officers to limit social visiting in certain areas of the site, but by and large, social visiting can continue. As well as admissions and transfers may proceed. So you can still have people coming into and out of your facility. This is under the guidance of the medical health officer who's actively involved in the enhanced surveillance. So conversations are being had, but essentially the whole site doesn't need to be on lockdown at this time. Whereas for these two criteria, if an outbreak had been declared, the site would be limited to essential visitors only, and admissions and transfers would be held for the duration of the outbreak as well. In terms of what things look like for the residents, so group activities and dining may proceed during enhanced surveillance. You may have specific residents that are on droplet and contact isolation, but we're not talking about, for enhanced surveillance, we're not talking about sort of site lockdown and multiple residents or units needing to be on droplet and contact precautions. During an outbreak, however, group activities and group dining are restricted. People will go to tray service as appropriate, and it's potential that there could be more residents or groups of residents that are on droplet and contact precautions. One key difference with enhanced surveillance is that public notification isn't required. So while we do report to the ministry that we have a site on enhanced surveillance, there doesn't need to be a public outbreak announcement because it hasn't met that threshold for outbreak yet. However, communication with staff is obviously paramount, as well as the residents that are affected, if there are residents affected because they've had to be put on isolation. If that threshold for outbreak is reached because transmission is evident at the site, then that's when the public notice comes into play. And just a reminder that any public communication is only released once all communication with the resident and families has been completed by the site. For enhanced surveillance, staff cohorting is not required, although it's something worth kind of preparing for and looking into how that could look for your site. Because if it is upgraded to outbreak status, then cohorting of staff to the outbreak unit is recommended whenever possible. And these points are general sort of comparison of the key areas and of difference. Ultimately, all the specifics for what your site might experience or may have had experienced if you've been on enhanced surveillance or outbreak is really under the discretion of the MHO and based on the specific case definitions and measures that are needed at your site based on the exposures and risk. When we're thinking about the staffing aspect, and if a staff member is the person who is positive, with the automated ability for people to receive their test results literally into the palm of their hand, it's possible, and it actually has occurred probably more often than not, that the staff member is going to be aware of their COVID positive status before communicable disease has been able to follow up with them and perform a full case investigation. In many cases, a staff member will call the site to say, hey, I've just been notified that I'm COVID positive, what now? So there can be a bit of a lag, and this was very true when we were seeing a lot of cases that needed that contact tracing. So part of sort of the mantra that we needed to maintain was to trust the process, that we know that there are key players and very good processes out there for communicable disease to follow up with case contacts, and that they do. And that sometimes we actually find ourselves in this wait and worry period where you've got this positive staff member, but the details you don't have yet or don't have a fulsome understanding of yet are when their infectious period was, who they worked with, when they worked, and essentially has your site been exposed or not, because it really depends on whether or not the staff member worked during their infectious period. So we certainly have had false alarms where staff have been positive, but because their infectious period happened when they weren't working, it means that your site wasn't exposed, which is like you kind of go from way up here to down here because your site was not exposed. If you're like me and you sort of get this information and you want to be a bit proactive, there are things that you can do proactively to prepare for if you do get a phone call in this way. So having a list of staff names and their phone numbers is definitely recommended as a proactive way of being prepared. If you're able to have a list of staff members' dates of birth, that's also very helpful. And the reason for that is during that case investigation, if you have staff that are identified as needing to be tested, it's easy to get that information to the call center, who can then be contacting staff to make those appointments. So, and the information they need to do that is the full legal name, phone number, and date of birth of the staff in question. And it is worthy to note that high-risk staff exposures are required to self-isolate for 14 days. So we have had experiences where, based on the level of exposure risk, significant numbers of staff have had to be on a 14-day isolation, even if they had tested negative, because because of the type of exposure that they had, it is possible that they could convert to COVID positive anytime in the 14 days after their exposure. So being mindful that, a big part of why we wear PPE and have a lot of these precautions and protocols in place, a piece of that is to protect our staff, knowing that healthy staff are able to come to work and maintain the resident safety and care that we all aim to provide. So for contact tracing, when you're thinking about staff, knowing who worked, so who was on shift, because what'll happen is you may have 2 or 3 days that an infectious person was at your site, and so then you need to be able to know, okay, who was on my site, who did this person interact with, what kind of was their job role. Interactions from somebody who maybe works in housekeeping or laundry are very different than direct care staff. And so having a good idea of where people work and what their interactions look like can certainly help when determining the risk of exposure. So being able to pull your staff list for those days, being able to narrow it down from all the people that worked on that day to just the shifts that were working during that time, and being able to pull even more precise information about who might have had breaks at the same time or congregated together, particularly breaks, because these are times when staff are removing their masks, and otherwise when they're out working, on the floor or in their specific roles, they should be having that mask on and eye protection as well when they're within 2 meters of a resident. So if some of the questions are also around, PPE use, was PPE consistently used? And if so, was it a medical grade mask and eye protection? because that also helps, falls into that risk determination for exposure. When we're thinking about our residents, we need to think of who might have come, cared for the resident, but we also need to think of the visitors that came in to see the resident during a potential infectious exposure. So having our contact tracing list at the front for all our visitors coming in can definitely help with that. Looking at the resident and their life in the facility, who do they eat with, who do they attend activities with, are all going to be important pieces of information that help add to that case investigation. So just a reminder that when we are talking about these close contacts or high risk exposures, the definition is that a person has been within 2 meters of a person during their infectious period without a medical grade mask on or eye protection for a duration of 15 minutes or more. And that those are the criteria that the communicable disease case investigators are looking for when they're gathering all this information. From that information, only the contacts who have been identified as exposed, those are the people we need to know about. We don't need to know about every single person. It's just those people that have been exposed in the definition there for close contact. When we're talking about transfer, and there was a recent update to our transfer protocol. So if you recall, in the beginning, when the pandemic was declared, and I'm going back to like March of last year, surgeries were canceled, hospital capacity was opened up. I think, in many sites, we are sitting at almost 75% or 80% of hospital capacity. And that was in response to an expected influx of patients requiring COVID care in hospital. And so and then as protocols came into place, better understanding of how to prevent the transmission of COVID-19 and the PPE supply increased, we've now been able to sort of adjust from having to put everybody who's positive into one place to be able to care for people on site. And that's a shift that we've seen in long-term care as well, that rather than sending, all residents who are COVID positive to a cohort site, we are now able to care for our residents on site as long as we're able to meet their medical needs. And if their medical needs exceed what can be provided at the site, and transfer is part of the resident's express goals of care, then the ability to transfer to the emergency department is available. We've also recognized that, with high vaccination rates, that the COVID experience of people who are vaccinated, particularly in our long-term care population, the symptoms and the sort of the disease is much less severe. So the likelihood of someone being who is vaccinated, who has contracted COVID-19, needing acute interventions like in intensive care, has decreased by 95%. That's essentially what the 95% efficacy rate is talking about. So it's really important that we're now able to get back to what do our residents want and what do they need, and is transfer part of their goals of care? So questions to be asking when, if you have a COVID positive resident on site is, are we able to meet their medical needs here? If not, do they want to be transferred? If that decision to transfer has been made, this is going kind of back to the usual way, in that the long-term care most responsible provider will make that decision to transfer, and will need to discuss it with the emergency room physician at the receiving site. The sending care staff at your site would need to then communicate in the regular way to the receiving site by means of a verbal handover, filling out that ED transfer form, and making sure all the printed material that's required for a smooth transition to care is provided. Also, that communication piece with the resident and family as well about the transfer. The big piece here is if you're transferring somebody who has suspected or confirmed COVID-19, that is a key information piece that needs to be communicated across all of the care settings, so that they can be prepared on the receiving end, but also so that during transfer, that PPE is in place and protocols are in place for the safe transfer and to reduce the transmission risk when we are transferring residents. And this, so this was this was brought forward to our acute EOC as well about this change in practice. And there are essentially sort of 3 things that can happen once the resident goes to the emergency department. So it's there that they'll be assessed by the emergency room physician, and that it's where their disposition will be determined. So they may be able to be a treat and return, and they would be coming back to your long-term care home. They may be needing to be admitted to a COVID cohort site, or they may need admission to an alternate acute care area. We do know that residents who may be COVID positive may still have other medical needs aside from the COVID-19 infection. Examples include something like a hip fracture that needs medical intervention, but maybe their their COVID symptoms are manageable. It's they have another medical need on top of that. So once you've done all that, eventually that outbreak is declared over. And by definition, an outbreak can be determined over after 2 incubation periods from the last known exposure, and that's about 28 days. One incubation period is 14 days. But it is also based on the medical health officer as well. So there are a lot of reasons and cases why outbreak could be declared over sooner, and that's really up to the sort of unique situation that's presenting at the site in question. So a terminal clean is an obvious piece of declaring the outbreak over, and that can often be a bit of a challenge because of, depending on the scale of the outbreak, you need to be able to sort of scale up your housekeeping staff to be able to terminally clean all the common areas, but also for all the residents that are on droplet and contact precautions, each of those rooms would need a terminal clean. And those take time. They're at least 2 or 3 hours per room to complete that work. It's important to note that the outbreak may be declared over, but if there are areas in the building that have not been terminally cleaned, that droplet and contact precautions need to stay in place until that terminal clean has happened. Our infection control group does have supporting procedures in place for terminal cleans after an outbreak is declared over that are available on the IPAC website. Communication is a big piece, especially in an outbreak, because there has been public communication through Island Health Communication. It is captured on the provincial sort of reports when they're talking about active outbreaks in the province. It's also been communicated to your residents and families. So it is important that follow-up communication happen to say this outbreak has been declared over, and to give people information about how they can safely resume visiting, or what the expectations are around that when they are sort of returning to normal at your site. Once the outbreak is declared over, visiting is able to resume, social visiting that is, and admissions and transfers can start to be looked at as well. And that's all in conversation with our teams here in Island Health to be able to facilitate a smooth reopening. Restocking of supplies, so being able to take a good look at what you've got left and what you need in order to be prepared and provide ongoing supplies for your staff in sort of a more normal setting. And then it's really recommended to be able to set some time aside to debrief with staff. It is something that the COVID response team can certainly help support with, because there is a lot of learning. We are actively living in a pandemic, and nothing's expected to be perfect. But what we should be doing is actively learning and looking to improve along the way. So being able to recognize what was done really well, identifying areas for improvement and how they can be addressed, or is a really important sort of closing piece to be able to share with your staff and with your teams to continue moving forward. And that is it for me. So I'd like to open it up. I see that a lot of people have sort of joined partway through. And Sarah, I'll send it back to you to start the discussion. Thank you.
Thanks, Marina. Yeah, so we've got Marina and Emily, who is our current director of COVID response, and Marlene, who is our response team lead. So if you guys have any questions you would like to ask, feel free to unmute or type it in the chat box or into Slido.
It's a super quiet bunch on Friday afternoon.
Yeah.
I wonder, Marlene, if you, because I know you've been involved in a lot of the supporting the work for when an outbreak's declared over, were there any pearls that came up for you when working with sites in that aspect?
Well, I really like what you said about the debrief. I mean, you know, there's the scene safety and clean that up. But I think the debrief is really, really important. And I've helped with quite a few of those. And I sort of ask 3 questions for staff that were involved. And especially I like to debrief with those, the staff that were cohorted to those units. And, you know, it's difficult and it's kind of like going to war. So I always ask, you know, what went really well? What made the difference for you during this outbreak? And I also ask, you know, what could we have done better? What were some of maybe the misses that we could learn from and move on from? And the last thing I always ask is, what are you most proud of with your response? Because there is a lot of there's lots of lessons learned, but there's lots to be proud of when you know, making it through the other side of an outbreak. And especially in Island Health here, we have had in every outbreak, knock on wood, as soon as we've gotten a hold of it, we've not had any transmissions. So the responses here have been outstanding and all due to the excellent response of our frontline staff, the people who actually do the work every day. So I think that debrief is, there are so many good pearls, and it's just also awesome to let your staff have that moment to celebrate themselves and what they've been through. Yeah, that's my 2 cents.
Thanks, Marlene. That's, yeah, really well said. It's important to celebrate those moments and sort of put the bookend on the end of the outbreak and move things forward from there in a positive note. Emily, anything you wanted to add?
Yeah, I'm not normally at a loss for words. Normally I have lots to say. I've got things going through my mind. You know, Marlene spoke a little bit about the end of an outbreak. I think we've learned a lot about the start of the outbreak, and I really appreciated, Marina, how you were talking about the slides and we've learned that it's often the case that it is the person, especially if it's a staff person, who finds it that they're positive before the site knows about it. Sometimes even, like you said, before contact tracing has done it. And I've spoken with a lot of site operators who are in that position, and wait and worry is really the best way to frame it. And there have been a lot of cases where we've found out about a staff person who's positive, and sites ask, what do we do now? Do we need to start putting all these measures in place? And what we try and counsel is, take a breath, let's wait, let's trust this process, wait for contact tracing to happen, and then we'll find out, because almost more often than not, it's turned out that the person didn't work while infectious. And then we think of it like a near miss. We think about, okay, we were lucky in this case, they didn't work while infectious. We're not going down the route of enhanced surveillance and outbreak. But I think it can't be understated just how much worry we get into that position, and the reminder that if you find yourself in that position, take a breath, remind your staff, if they're worried about it, take a breath. We can trust our partners in public health that they'll be following this through and figuring out and guiding us in terms of where we need to go with it. Mm-hmm. The other thing I'm thinking that we could have a little bit of a talk about is Well, I should have told you this, Marina. This is where my mind is going. Is that we're in this interesting time in the pandemic where we have some practice managing outbreaks. We're probably going to be living with COVID for a while and responding. People are getting a little bit more used to responding to COVID. How are we going to be moving into kind of the next phase? And I'm kind of curious, Marina and Marlene, your thoughts on that.
Well, and I think that's actually has come through a little bit in the some of the updates that came this week about the essential health visits. So speaking about people coming onto the healthcare practitioners coming onto the site, that we don't need to limit that to essential anymore. And looking at, okay, so we know they can come on the site, and what does that look like? So remembering how we had healthcare providers come on the site, but also knowing that we just need to do it safely with these sort of COVID layers on it. And I just sort of keep getting the feeling now that we're moving back to normal with these like just layers of COVID on there that are more about the same fundamentals we've been doing this entire time when it comes to a lot of our PPE and a lot of our approaches that we know work. And that's, I think that's really evident when with our experience here in Island Health, we haven't seen these huge outbreaks with mass unknown transmission. We have been able to quickly identify, enhance surveillance or outbreak, quickly contain, and sort of with the kind of constant measures in place and then additional measures as required, really been able to effectively run an outbreak. And I think that's an important thing to remember too, is that, you know, a positive person at your site or enhanced surveillance or outbreak is not a failure. A well-run outbreak with effective containment is a success. And that's what literally that's what we've been training for, and that's what we've been doing, and that's what we've been showing that we can do effectively.
Marina, what it's making me think is just like we're saying, trust the process when we're talking about contact tracing. I think at this point, we can really say that we can trust our process in terms of outbreak management. You know, we've gone through it with several sites before. We've seen that our measures work, that our response works, that our protocols work, and we can trust our response process as well because we've seen just how effective it is. And Marlene, do you want to speak a little bit to that? Do you have anything you'd like to add?
Well, I would, but I noticed that Nicole has come off of mute, and I'm just curious if you have questions or comment, Nicole.
Yeah, sorry, I didn't want to interrupt. I was actually one of the things that keeps coming up at our staffing. We've been trying to talk about this sort of at least once a week with our staff and sort of how they're feeling and all that kind of thing. And the one thing that keeps coming up is around the person, everyone being afraid to be the positive, right? And the guilt and the stress associated with that. And I've just wondered for the sites that have had that happen, sort of the supports and stuff to help that person. Not that it's in any way, you know, their fault or they did this on purpose, but I know that they feel that way. And I don't think any of the staff are going to ever judge them, but I think they judge themselves really harshly. And I'm just wondering, you know, sort of in the debriefing that you were talking about, what, you know, how to help them.
Well, always with kindness. I mean, that's one of the things that we talk about at the beginning of an outbreak, how important it is to remember, number one, about confidentiality. So what we don't want is people to speculate about who and how and all of those things. And also kindness, because Nicole, you've really hit the nail on the head there. It is hugely concerning to be that person. And so we really do encourage compassion towards our colleagues, and, you know, to encourage folks to reach out to support them if they're, you know, if they're in an appropriate relationship to sort of do so. So yeah, kindness and compassion, because I would be horrified. I think we all would be. So Yeah. And all of the normal supports as well. So we have pages of psychological supports and just to reach out. We've got PHSA has a mobile team that is available. So I just try to lay out all the supports possible. Mick,
have those gone out to any of the sites with outbreaks?
I'm sorry?
Has that been deployed on the island here to sites with outbreaks?
Yeah. Yeah, they actually...
Lovely.
Well, and they don't come out, of course, they Zoom into the site.
Right,
they will do either group chats or individual, because you know, we've sort of found that the major debrief together was a bit intimidating and folks aren't really comfortable. So there are lots of opportunities to talk just one-on-one with counselors there. So there's lots of good supports there, Nicole. Thanks for bringing that up.
Thank you.
And the other piece I'll add too is just because a person's been identified as positive doesn't necessarily mean they were the one that quote unquote brought it into your facility, because they're the first person we know about because they did all the right things. They recognized that they had symptoms, they stayed at home, they got testing, and they let their site know as soon as they had their results. We do know with COVID, there is that asymptomatic period where you're not even aware that you have symptoms. So how can you not go to work if you don't even have symptoms? But also we have had instances where, you know, we had the positive, but then it became clear if there was other positives around, it wasn't clear. And it doesn't actually matter where it started from. It just, you need to know the connections and where sort of the bubbles get to. So it really, and when there have been higher rates of community transition, it is possible that, you know, it's like more than likely acquired in the community and then brought in, but you can have two separate community acquisitions that work at the same site as well.
Same time.
So it's really complicated. And while people, you know, do place,
which ideally, you know, it's not nice, but at least then hopefully those people can't, you know, put that solely on themselves.
Yeah, and I think the focus is if you have early recognition for your symptoms and follow through, you've done exactly what you needed to do.
Yeah. Yeah. And no, you know, we've been lucky. We've had a couple that we had a really good vaccination on our site. So we've had a couple of people that have been exposed. Luckily, they've never developed any symptoms at all. But I know for them, it was that just, yeah, they just really beat themselves up about it. Even though they completely did the right thing and really, you know, were stellar in that way. But it's, yeah, it's a hard piece, I think, for them just because they care so much about their staff and their residents.
Great, thanks so much, Nicole. That's great question, good discussion. Did anybody else have a question or a comment that they wanted to bring forward? Well, in that case, I will I'll end things a couple minutes early, give you guys a couple extra minutes with your day. Thanks so much for joining. I'm just going to quickly post the link to the survey back in the chat box. Feedback. If there's a topic you would like covered in the learning series, please let us know. And yeah, thanks so much for joining today. Hope you guys enjoy the rest of your Friday and have a good weekend.
Thanks so much.
Thanks, guys.